I'm Dr. Stephen Meletiou. I'm a hand surgeon with Twin Cities Orthopedics. I'm board certified in orthopedic surgery, hand surgery, and sports medicine. And my interest is the upper extremity. Today we're going to talk about distal radius fractures, also known as wrist fractures. The fascinating part for me is no two are alike, so each one you're trying to figure out exactly the best way to treat it for the patient, but technically at the time of surgery you're figuring out, how do I get Humpty Dumpty back together again? There's a lot of fragments here, a lot of pieces. We want to make it look perfect. We want to give this patient a good outcome with respect to their function. So how do we do that? And to me, that's the technical aspect of this that I find fascinating, because it's a challenge. So the wrist is the joint where the two forearm bones connect to the hand and forms the wrist. The two forearm bones are the radius and the ulna. When people break the wrist, they're usually breaking the radius. And rather than breaking it up in the mid-forearm, the break is down closer to the wrist joint itself. So wrist fractures generally occur with a fall onto an outstretched hand. So typically falling forwards onto both hands or onto one hand. We usually see a rush of wrist fractures after the first ice storm of the season. We see a lot of wrist fractures in the older population where the bone density is not quite as good. We also see a lot of wrist fractures in active young people because they're very active, they're playing sports, and a lot of contact sports and even non-contact sports can result in various falls. So there are two general options for management of the fracture: cast treatment and surgical treatment. For a lot of young people, particularly active athletes and patients where the bone hasn't moved much, cast treatment can result in a very good outcome. But when the bone has moved quite a bit, and especially in older patients where the bone quality may not be quite as good, surgical treatment can, in many cases, result in a better outcome. But there are risks with surgery and risks in general with these fractures. There can be risks that it doesn't heal in the proper alignment, although generally with surgery, we hope that risk is very minimal. There can be risk of infection, but again, very minimal risk with that. There can be some issues where the hardware maybe in the future needs to be removed, and that risk may be at most maybe 4%. But in general, the risks with surgery are pretty low. The incision is usually on the palm side. There's a little plate that's shaped somewhat like a T, kind of a cross between a T and a Y. There are screws that go through the plate that capture all the bone fragments, and that stays in permanently, unless the plate causes some tendonitis, and in rare cases it can, maybe about 4% or so. So the plate adds a lot of internal strength to the bone before the bone has even begun healing, and that's why we can cheat, if you will, and get you moving pretty early. So cast treatment versus surgical treatment have two different postoperative recoveries. With cast treatment, you're typically in a cast for about 6 weeks. Your fingers are free in most cases, and the elbow is free, but the wrist is immobilized. At the end of 6 weeks, you come out of the cast and start working with the therapist to regain your motion. With surgery, you're only immobilized for that first week to 10 days in most cases. Then the dressing comes off, and then you start to get your wrist moving at a much earlier time. You're using a removable splint for protection, but you can take it off on your own to do light activities and to pursue your therapy at home.